Good afternoon, everybody. I'm Steve Tang. I have the honor of being the President and Chief Executive Officer of OraSure Technologies. And on behalf of the OraSure family of companies, I want to welcome you to this panel discussion to commemorate World AIDS Day. So whether you're joining us here in New York live and in person or by webcast, we want to thank you for spending your time with us today. We're going to take an interesting look into our panel topic, which is the 40-year story of HIV, then and now. In support of this occasion and in remembrance of World AIDS Day, we've engaged leaders from the HIV community to reflect on the last couple years and how we can work together to address the gap in HIV testing and treatment during this time of COVID. This panel discussion will be moderated by Deborah Fraser-Howes, the incomparable one, founder of the National Black Leadership Commission on AIDS, who also advised two U.S. presidents, President Bush II and President Clinton, I believe, and served on the President's Advisory Council on HIV/AIDS. Before I turn it over to Deborah, I'd like to call for a brief moment of silence in honor of the millions of people we've lost to HIV and to AIDS. The countless sons, daughters, husbands, wives, brothers, sisters, relatives, and friends who are mourned by those who love them. Thank you. To set the tone for our panel, I'd like to share a short but powerful video with you.
Thank you, Steve, and thank you so much for your leadership. You've been a fantastic leader of OraSure Technologies. Proud to be a part of the team, and so happy that we have these great people here who've come today to be panelists and discuss in this great institution what it means to do treatment and testing and just the epitome of what their lives have been in working in this epidemic for the last 40 years. So proud to be a part of this. We want to begin, though, by, they're all friends of mine, so that's a good thing. I want to begin, though, by introducing another friend of all of ours, Harold Phillips. Harold is President Biden's director of the Office of National AIDS Policy. We used to call this position the AIDS czar. Many years ago, and Harold is a good friend, and he could not be here with us today because he's putting together an event tomorrow morning for President Biden, and he's going to have some great announcements for everybody in this fight against HIV and AIDS. So we can start that video.
This year's World AIDS Day theme, Ending the HIV Epidemic, Equitable Access, Everyone's Voice, underpins our commitment to ending the HIV epidemic everywhere. Equity in access, meaningful engagement, and collaboration across all sectors and levels of government and society. Our commitment to ending the HIV epidemic everywhere means that we must innovate our approaches and invest in communities and populations to end the HIV epidemic through strategic and thoughtful planning and programs that address health equity. Also, expanding access and ensuring the voices of people with HIV and people with lived experiences are central in all of our work. Equity in access means that our efforts are informed by voices from the most impacted communities, where we need to work to put equity at the center of the response. And additionally, we need to work to strive to ensure equity in our programs, research, policies, and planning. There's still much work ahead to achieve equitable access to HIV prevention, care, and treatment in every community, particularly for communities of color, adolescent girls and young women, especially Black adolescent girls and young women, the LGBTQ plus community, and other key affected populations. Meaningful engagement means that community and civil society engagement, which we have known for years, is vital to ending the HIV epidemic everywhere. The Ending the HIV Epidemic in the US initiative continues to implement community-driven solutions by addressing racial, ethnic, and geographic disparities that continue to impact people's lives. Globally, the President's Emergency Plan for AIDS Relief works with partner countries, multilateral organizations, community and faith-based organizations, and other critical stakeholders to deliver quality, people-centered HIV prevention and treatment services. Together with private and public entities, we will explore new and innovative ways to partner with communities and leverage the experiences of individuals living with HIV to help end this epidemic in our domestic US response. Collaboration across all sectors and levels of government means no single entity can end the HIV epidemic. Protecting and further expanding HIV progress requires a sustained commitment from all of our sectors of society using a whole of government approach around the world. And working together, that we will leverage our respective advantages and strengths to ensure that HIV services are available and that we continue to provide access to people of every age, gender, and population group in the United States and around the world. The Biden-Harris administration is committed to ending the HIV epidemic in the US, and we will continue to try and support our communities as we work together collectively using the National HIV/AIDS Strategy, which was released today as part of this effort. So, as we commemorate World AIDS Day in 2021, let's use the passion and commitment from this day to carry us forward toward an end of the HIV epidemic. Thank you.
Thank you, Harold. We have a friend in the White House, and that's a very good thing. I want to introduce our panel today. Dr. Stephen Lee is the Executive Director of the National Association of State and Territorial AIDS Directors. Stephen has been in charge of all overall programs and operations for NASTAD. He is also a physician, which gives him very keen and specific insight into some of the AIDS policy work that we do around the country. Before joining NASTAD, Stephen was a part of the, and head of global HIV policy for the Elizabeth Glaser Pediatric Foundation. Dr. Vince Guilamo-Ramos is Dean of the Duke University School of Nursing and Vice Chancellor of Nursing Affairs. Vince has been renowned for his work in adolescent sexual health worldwide. So we have a true leader in that area here to discuss what has happened before, what is going on now, and what we can look for in the future. Vince has been tenured professor, there's so many titles and stuff here. He's tenured professor at both New York University and Columbia University. Ingrid Floyd is the executive director of Iris House, and she also now shares the title of interim executive director of WORLD, the Women Organized to Respond to Life-Threatening Diseases. I had the pleasure and honor of sitting on Ingrid's board. She is a masterful leader in the not-for-profit world. Before Ingrid came to work in the not-for-profit world, she has had more than 10 years of experience in the business sector as a senior manager at Deloitte Consulting and manager in residential properties. Mark Meacham, another very good friend, has been head of U.S. External Affairs at ViiV Healthcare since 2009, where he directs all U.S. external programs. Mark has been in the pharmaceutical industry for more than 2 decades in various roles from therapeutics and commercial and marketing and management. He has a bachelor's degree in language and literature and economics from the University of Pennsylvania and an MBA. He's been from Duke University. He has been also another master in linking community and corporate America together as we move through this epidemic. So, guys, and young lady, we have been in a situation where we've seen a video, very powerful video, by the way, OraSure, that certainly took me back to 1987 when I founded the National Black Leadership Commission on AIDS. It was just too much death and I couldn't stand it anymore. Had to do something. So we've been in this thing for 40 years. And if you can remember, it was called the gay-related immune deficiency disease. It was supposed to be only in one community. We find out later that it's in all communities. It's worldwide. And 40 years later, we have lost millions and millions of people to this epidemic. So let me start with the first question. What do you see as the most significant innovations that have been introduced relative to HIV treatment and testing since you've been engaged in the fight against AIDS? And what do you hope to see on the horizon? So, Vince, let me start with you, and then I'll go to Stephen.
Sure. It's a great question. So I think there's a lot that I could say, but I'll maybe focus on a couple of things succinctly. First and foremost, obviously, antiretroviral treatment. Game changer. There was a time early on, when I think back to 1990s, that the adolescent AIDS program, where I eventually wound up working as a nurse practitioner, we were primarily an inpatient program. When I left Montefiore Medical Center just a couple of months before joining Duke, we're primarily an outpatient program. And, it's very rare that people are actually in the U.S. hospitalized because of complications associated with HIV disease, particularly if they're in treatment. And so I think ARV is certainly a major advance and something that we should all be very thankful for.
Stephen?
Great, thank you, and thank you for inviting me to this panel. So I, like Vince, started early in the disease, and I was a medical student and seeing young men dying on the wards during my second year of medical school. And so I absolutely agree 100%. When I finished my residency is when antiretrovirals first came out. But one of the things that I would focus on as an innovation is testing. And for us to be successful, people need to know their HIV status. And so advances in testing, I think, has really enabled us to move forward. The couple of things that I would mention is the policies around screening, and coming from Elizabeth Glazer's policies around screening pregnant women and getting pregnant women to know their HIV status so they don't pass HIV on to their babies. But then also advances in just diagnosing of HIV. So here we are, we're now at the 4th generation antigen antibody HIV tests, and so diagnostics has been important. But we also have point of care testing. And so opportunities like the OraQuick at in-home HIV test are opportunities for us to do self-tests at home and or point of care testing, and people knowing their HIV status so they can either get started on PrEP to prevent infection or get started on treatment.
Thank you. At one point we were faced with losing ground in our testing paradigm because we had a situation called COVID and we weren't allowed to be close to people, to give them tests. But the fact that we had an in-home test already, and we were able to ensure that the public health departments got hold of the in-home test and were allowed to send that in-home test out to individuals who needed to be tested, and they could test themselves and their partners, was a game changer for ensuring that we did not lose all the ground that we had gained. Ingrid, you you were working on one of the first programs to deal with women and children, and in the middle of Harlem, where the crisis was very, very great. Can you tell us can you answer that question for us, the most significant innovations in testing and treatment?
Sure. I think as both panelists have already said, when we think about just where we've come as far as treatment and testing, it's just been just whirlwinds of change. So, initially when we talked to a lot of the women who we treat and care for at Iris House, people were on 25, 30 pill cocktails. And now to be able to talk to people about a once-a-month injectable, which could definitely, for us, we deal with stigma and we deal with the fact that there's a lot of issues with women around disclosure. So now to be able to talk to them about options that allow them more privacy, allow them more confidentiality related to disclosure and who and where to disclose, as well as just testing, and the fact that now, when I'm probably, one of the young ones in this work, even though I've been doing this now for over 16 years, but when I was in college and had my first HIV test, and just the anxiety of waiting a week to get a test result in the mail, versus now people can come into a community center like Iris House, get tested, and leave within 15 minutes knowing your test result, really changes the paradigm for people who are willing to be tested now. People who now we want to normalize testing, so being able to offer a rapid test normalizes the testing process, as we talked about point of care testing and all these other opportunities, really has helped us change how people think about HIV testing, as well as how people now think about HIV treatment.
Thank you, Ingrid. You brought up another point, an intervention in the 40 years. Remember when people were getting tested, and again, going to the hospitals and the doctors to get tested, and wouldn't return for their test results.
Yeah.
So having a rapid point of care test changed the world, and people got to know their status in a few minutes, and they were able to make informed health decisions based on knowing their status. Mark, let me ask you that same question about the innovations that you've seen in treatment and testing since you've been engaged in this pandemic.
Well, I think certainly in terms of treatment, when you think from the beginning of AZT monotherapy, which we now know is insufficient, to combination therapy, but was still complicated at the time, multiple pills, multiple times a day. And then you have the evolution to singlet tablet regimens, so you can have a once-a-day treatment. A further level evolution has been the movement toward less medicine on board. So now you can have a single tablet regimen that has just two components, two medicines in it. The second one, I think, is, as Ingrid said, is reduced frequency of dosing. So with the innovation of going from 365 to 12 injections a year, and then there's work going on to take that to 6. So the idea of going back from 365 times a year, days a year, to 6 days a year, I think is incredible. And then furthermore, I think this is always in the field that we always have to think about the needs of patients, and patients need multiple options. So the field is continuing to look at, and we're continuing to look at other dosing formulations, including ultra-long lasting formulations and others, because, people need options, and the right option for the person is the right option for that person.
And your company has certainly been a leader in that field. I mentioned a little while ago what challenges were brought to bear because of COVID. And what has happened around HIV testing and treatment. And, people talk about COVID, and, very often we tend to forget, because we're so caught up in that particular pandemic, that people are out here and very, 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 very ill. And a lot of services are not being given. A lot of things are not going on that should be going on in the community, particularly in communities that are in greatest need, communities of color, communities that are disadvantaged. And what do you think, with these challenges that were brought on by COVID to testing and treatment, What can we do as a community to continue to advance testing and treatment in these communities that are in such dire need? Go ahead, Vince.
So I guess, Deborah, I might answer that question slightly differently. So for me, COVID did a couple of things, and then I'll relate it to testing and treatment. So first and foremost, it really made clear historical inequities. And so I think some of it we could say was brought on by COVID, but a lot of it was already there, and actually COVID made that really transparent. I also think that COVID applied a lot of pressure, as you said earlier, to our health system. As the Vice Chancellor for Nursing Affairs at Duke Health System, everything was COVID, and everything was redeployment and response to COVID. And so that meant that there was a real shortfall in terms of our ability to test, to treat, to follow up people living with HIV. And then I do think that there's some emerging data that's suggesting that there have been synergistic effects. And so while we've made lots of progress in terms of this 40-year anniversary where we are now, I think we need to be somewhat humble and pay attention, because we don't want to go backwards. There are still too high a number of new infections in our country. Certainly ages 25 to 34 is a group that we should be very concerned about in terms of testing and treatment. And I think, Deborah, some of the populations that you've identified already, women, Black women in particular, the South, young MSM of color, et cetera, people who use drugs, I think we need to be vigilant.
Yeah, we do. Ingrid?
So I think as we heard in the video earlier, when we think about equitable access, I think what COVID helped to just expose is that equitable access does not exist in communities of color around this country. And really, when you think about things like HIV, it just exacerbated a problem that was already existing. For us, I think one of the challenges is how do we continue to address the mental health issues, the substance use issues that were brought to light as a part of the COVID pandemic, because a lot of those are the things that we know are reasons for why people become infected with HIV, why people are at risk of HIV. We have seen at Ours House and across the country lower HIV testing rates as a result of COVID. One of the things that we want to see are more people now coming back out and feel comfortable accessing HIV testing. We've also seen drastic increases in sexually transmitted infections, which again, when we think about all of those preceptors for how people come into the door with an HIV diagnosis, how do we make sure that we're addressing and making sure there's access for everyone to be able to get these services, to get tested, and to feel comfortable, again, just coming out and accessing the services in a place that makes sure that it's culturally appropriate, culturally sensitive, and also gender responsive to the needs of the community.
And Ingrid, you're going to have your work cut out for you for sure, because the CDC just released a document saying that over 140,000 children have been orphaned because they've lost either a primary or a secondary parent to COVID. And most of those children are Black and brown. Yes. So we have a yeoman's amount of work to do in that area. Mark?
I think one of the things that's important on this 40th anniversary is to know that there is light at the end of the tunnel. It's like we can end the HIV epidemic, and we have a goal to do that by 2030. But I think, there's the phrase, time waits for no man, so you can't wait till 2029 to start that work. And so we know we've had the interruption of COVID. We know we probably had some elevated community viral load, but really that work to end the epidemic by 2030, we have to do really, in these next couple of years between now and 2025, the experts say. And I think it's important for people to realize that standard of treatment and care we're talking about is working. So it is working for white MSM population. White men who have sex with men are seeing dramatic decreases in cases. But when we look at people of color primarily, we're not seeing those same gains. And back to that notion of equity, everyone deserves to benefit from that standard of care.
Thank you, Mark. Stephen, we've seen so much similarity between COVID and HIV. When HIV first started, it was a lot of disinformation. People were afraid to get tested. They were afraid to get treatment. And it's all back again. So how do we, as a community, sort of address the treatment and testing in these challenging times?
Yeah, I can share with you and with the audience an experience that we've had at NASTAD through a program called Take Me Home. And Take Me Home is a program that was developed by Building Healthy Online Communities in partnership with NASDAQ and Emory University. And it was is a program, it's an ongoing program started in early 2020, where HIV rapid tests were procured by health departments and for their constituents and residents at no cost. And people were then able to do HIV tests at home. We've done some interim analysis of the data, and over the past year, over 5,000 people have actually accessed rapid tests through the Take Me Home program and the Building Healthy Online program. Over 5,000 tests have been procured and provided, and these tests were the OraQuick in-home HIV test. 36% of those individuals had never tested before, and so really took advantage of this opportunity for a home test. And 34% of those individuals also, during the COVID epidemic, the ongoing COVID epidemic, were experiencing decreased abilities to access and find testing services, whether in their community or in their clinic. So this is a program that really offered an alternative approach to that in-person testing, clinic testing or community testing through a home test. And one of the key components, going back to some of the conversations around equities, inequities actually, and inequalities, we really have to make sure we interrogate that data to make sure that the folks who are accessing those tests, we're seeing the gamut of racial, ethnic minorities and populations most likely and most at risk for progression.
That's great success. Another hats off to OraSure for an innovative product that allowed for us to test people who were not getting tested in the midst of a global pandemic. So hats off for that. You know, we as the AIDS community can be rather siloed. For 40 years, we tend to stay in our lane, do our work. We've become experts in what it is that we've done. But we do need to interact and broaden our perspective. How can we, in the AIDS community, I know sometimes we're a little standoffish to corporations, since all of us have corporate experience and understand the importance of public-private partnerships and those kinds of endeavors. I mean, you look at COVID, and the government wasn't able to make an adequate test for COVID, yet OraSure, some other companies, but OraSure also in particularly, now has a groundbreaking COVID test where you can get your results in about 30 minutes. And simple swab, lower nostril, put it in and people are used to the technology. You use a little tube, you put it in the tube, and you can get your result. Looks like a pregnancy test. It's one of the things that they did around Ebola. And it's one of the innovations that helped save lives in Africa. So we understand the importance of public-private partnerships, but I want you all to speak a little bit about that and the importance, and in your lives, what you've found in AIDS, what do you see as the importance of public-private partnerships? Mark, I'm going to start with you. Mr. Vive.
Well, I think one of the things at Vive Healthcare, we always felt that, we need to go beyond the medicines. So the medicines are not enough alone, and we need to address, what we call in the field of social determinants of health, but those barriers that get in the way of people accessing care. And so I think that's one of the critical things. And I think, as Harold Phillips said, a whole government approach, and equally, I know that the administration wants a whole society approach. So we want, when we think about the epidemic, it is the disparities are focused in 57 jurisdictions. So who are the companies that are present in those jurisdictions? It always doesn't have to be, a humongous company. Who are the medium-sized or the small companies who are present in those communities? How can they help educate their employees? How can they help educate their community? Again, I think with the view towards we can do this. We can end the epidemic. We've got a date and a plan, and let's do it.
Ingrid?
I'll take it from the perspective of a community-based organization and from the nonprofit perspective. I think that there are just great opportunities to be able to engage experts in the field and in the community who've been doing work in the local communities. So making sure that when we think about public and private partnerships, we're engaging New York being a prime example where most people here are in nonprofit, right? There are almost 1 million person workforce here in New York City that have that expertise of being in the community, working. We know how to do housing. We know how to do substance use treatment. We know how to look at mental health and HIV. So making sure that we're utilizing the knowledge base that exists within nonprofits and for people who are the boots on the ground doing the work as we think about future innovations, as we think about future interventions to help us to make sure that we continue to advance where we're going around HIV and ending the epidemic.
Stephen?
Sure, great. Like Ingrid, I also think broadly of public-private partnerships and beyond nonprofits, and I wholeheartedly agree, community-based organizations, nonprofits ought to be part of the conversation, but we also, Vince knows this, we need to make sure academic institutions are part of the public-private partnerships. We need to make sure that those organizations that provide healthcare, health service delivery are part of the partnership. Even health insurers, people, organizations that provide insurance and thus access the health services for individuals are part of the public-private partnership, philanthropic organizations, foundations, religious groups. So my perspective is a broader definition of public-private that goes beyond thinking of companies, but beyond and thinking more along communities, philanthropic, foundations, et cetera. And I'll just end by saying I think ultimately all of those public-private approaches need to lead towards equity. And we need to be thinking about, as Mark just articulated, how those partnerships lead to addressing the social determinants of health, addressing access to health services, and the inequities and inequalities that currently exist.
Vince?
So I really like what you said, Stephen. I'm going to focus on healthcare. As a nurse, I want to make a couple of important points. So first and foremost, HIV, if we can end this, which I agree with Mark that we can, then that raises questions around, can we end other chronic diseases in our country? And to me, that is something that we all should be on board for. And that requires partnerships, a societal response, investments in public and private. And I think that's really what's at stake here. I think there's some low-hanging fruit. And so for me, the one that's the most obvious, but I'm the dean of a school of nursing, is that we have a nursing workforce of 4.3 million in our country. It's the largest segment of the workforce that we have. Most healthcare across the planet is delivered by nurses. That's a fact that too few people understand and know. If we were to mobilize partnerships with nurses and other healthcare professionals, and if we could have broad definitions of who we bring to the table, all hands on deck, we could end this. And we absolutely need to be thinking about not just new partners, but the ones that we haven't leveraged. And I would argue that nurses are the most obvious.
This has been wonderful. So where we are now in the three questions that I've asked you, if you can't test it and identify it, you can't treat it. And that's very, very critical. And both testing and treatment are two critical pieces that we need to continue to push forward. What we've learned from COVID is that there needs to be public-private engagement, there needs to be community engagement on the ground, and that we should take from what we've learned from other diseases like HIV and AIDS and address some of those same barriers that we see coming up constantly, and understand that this will not be the last pandemic. So pandemic preparedness is going to be important, and we need to be ready to move forward. And we want to thank OraSure for both the COVID test and the HIV test and the HCV test, because they have been moving forward as needed as the community, as you can see, has laid out what challenges they're facing and how their tests and their products have addressed those challenges. How can we organize and deal with these silos that we live in? We've got a friend at the White House. We started out with a discussion from Harold, and we're happy about that. Harold is releasing a new plan on HIV and AIDS. It will include public-private partnerships. It includes looking at rapid testing, point-of-care testing, over-the-counter testing. It includes all of these things, and he is very, very clear on the intersection between COVID and HIV and AIDS. I think the final thing that we need to say is that one of the things that we need is for the private community to embrace what's going on in all of government. All of government has had a response, particularly more recently, that's very progressive. And they're looking at who it is they need to partner with, and how can they get tests on the streets, how can they get vaccinations in people's arms, and we should be able to, as a corporate community, help them move that agenda forward so that we can all live, because that's the whole point of this thing. And I want to thank all of you, our panelists, for being with us today. You have been absolutely wonderful, as we always knew that you would be. You've been wonderful, and we thank you very much.
Thank you.
Thank you. Thank all of you for participating with us and being here with us. Thank you. Are there any questions? We'd like to open this up to questions, and if you have any questions for any of the panelists, we would be happy to take any questions that you have.
I'd like to hear a little bit more maybe around what you see in the future. You know, what are some of the innovations you can see or foresee, or what's needed to really kind of bring an end to this?
I can start. One of the things that we haven't talked about on the panel so far and conversation so far is around prevention, right? So we started with testing and we went to treatment, but in the middle is preventing transmission, preventing HIV. And some of the innovations we've seen that comes to mind are PrEP, or pre-exposure prophylaxis, and the fact that we actually have a pill to prevent HIV, and if our colleagues at ViiV are successful, we may have an injectable to prevent HIV transmission as well. But we also have other modalities. I think just this year or late last year, the vaginal dapivirine ring was approved, and it's a modality and approach that gives autonomy and control to women to prevent HIV transmission. So the opportunities around prevention and innovations around prevention are opportunities that I see now, but also for the future. And going back to our theme of equity, the key thing is to make sure that all people have equitable access to those prevention strategies and prevention modalities.
Anyone else like to respond?
Sure. So Ron, I think for me, the sort of thing that is looming is this issue of the workforce. We have increasingly people living with HIV, and that's a good thing in terms of living long, healthy lives, but requiring primary care and needing not only HIV care, but comprehensive care. We are experiencing a massive shortage in terms of our workforce. I don't know if folks realize that the number of infectious disease physicians that are entering that practice has been diminishing exponentially. If we think about areas like the South, where there's still a booming epidemic, we have very few primary care and infectious disease docs. And so we have to, as a country, think about how are we going to care for these individuals, and how are we going to ensure that we can get every American access to quality primary care. And for me, that means thinking about things differently and innovating, and also partnering around technology and point of care being fundamentally different than what it's been, which has been brick and mortar structures, but increasingly in the home, in the community, in sort of decentralized settings where people are able to access what they need.
Yeah, and I'll just add one last thing to that, which when we think about kind of the future of this, is that, you know, the data shows us that majority of people living with HIV in the next few years will be over 49. So how do we make sure that in this workforce that we build, we make sure that there are people who understand HIV along with aging, and as well as things like oncology. Like we're seeing a lot more of the women that we're treating and people coming for services who are facing oncology issues along with HIV, but not a lot of specialists are familiar with how do we make sure when we think about the side effects of HIV medication, how does that react to chemotherapy, how does it react to cancer treatment? So how do we make sure that as we build this workforce that we're also building specialty around HIV and aging and doctors and providers who are going to be able to help people because we know that that's what the future of this looks like for the people who are going to be living with HIV. So we're grateful people are living longer, but now we got to make sure that we have providers who are going to be able to care for them.
And
Mark?
I'd just add to that, I think two things. I think is flexibility and resources. So in terms of resources, when we think about these 57 places in the U.S., Puerto Rico, and the territories where we have to be to end AIDS, it's like these are traditionally under-resourced communities. And so we really have to find a way to put resources into those communities and also involve people in their own solutions, because you can't go into community on a white horse and say, we're here to save you, without engaging people and really listening first. And then I think in terms of flexibility, it's like there are some things that have been just tried and true, but even just simple things like access, like can you go to the clinic after 5 o'clock, or on the weekend when you're not working. So, I think there's innovation, and then sometimes there's tried and true, and I think we need to do both.
I want to add something to this too. One of the things that we've certainly learned for both COVID and HIV, the two pandemics that have attacked us in my lifetime, is that we live in a global community. And we better start acting like we live in a global community. We have to, do what we need to do on these shores for America and for our communities and our people. But we also have to know that if anyone is impacted, all of us are impacted. And it behooves us to certainly express to corporate America, the government, and everybody else, that where we need resources, we have resources at home, we need more resources at home, but we also need resources internationally. We need to continue to fight against AIDS internationally. We need to continue point-of-care testing internationally. We need to continue the COVID testing, vaccine, and treatments internationally, because I believe that it's going to save our lives if we take care of our brothers and sisters. Any other questions?
You guys have been great. Thank you.
Thank you.
I love some of the points that you bring up around prevention and obviously equity, which is huge. And my question is towards prevention. I'd love to hear your thoughts about the younger generation and what to do about gaps in information, disinformation, because I have two young boys, and I fear that by the time they come of age, my oldest is 7, that they'll be like HIV. I hope they'll be like, what was HIV? But I don't want it to be like, oh, what was HIV? Mom, I didn't know, and it's still around, and you get where I'm going with this.
Ingrid, I would like you to take that one on first.
So we are at a point, like we do, ourselves does a lot of programs around youth. Ophelia Barrios, who's our community health initiative director, knows because she runs a lot of these programs. I think a part of it is that we have to start talking to kids about these things earlier, right? We wait until kids are in middle school to think that's an appropriate time to talk about sex education and health and your body and how your body works, and it's not. We've learned, and we've seen this over and over when we think about STIs and we think about HIV, that kids learn from social media and their friends, and both give them the wrong information. So I think a part of it is taking a bold stand that we have to start educating kids younger. We have to make sure that misinformation is factual information. So how do we make sure that we counter that? And a part of it too, I think, is also educating parents to be comfortable having conversations with their kids. A lot of parents, we were talking about this last week, and somebody said to me, like, they didn't know anyone with HIV, and I'm like looking at them like, you know why you feel like you don't? Because no one is talking to you about it. Mm-hmm. No one is sitting around the dinner table at Thanksgiving and openly saying, I'm living with HIV, because families still aren't talking about it. So I think a part of it, that education for our young people, is how do we make sure that they have the right information from the right source? And how do we use things like social media? Because we buy in, right? That's how you want to get your information, and we have to buy into. We then have to put information out to you through the channels that you're going to listen to. So making sure that we as organizations and companies are putting out factual information through the channels that young people will actually listen through.
Anyone else?
Sure. So I feel like I have to answer this question.
You have to. That's a must.
So thank you for that question. I have spent 30 years of my life focused on young people and sexual and reproductive health. And I think, despite all the progress that we've made as a country, I think when you really zoom in on the data for young people, there is somewhat of a different picture. Never before have we had as many STIs, and half of those STIs are among adolescents and young adults. When we think about awareness of HIV status, linkage to care, retention in care, sustained viral suppression, young people stand out as having the hardest time. And so what do we need to do? I think Ingrid raised a lot of great points. We need to start realizing that young people are just not small adults, but they actually need a different way of care, of engagement, of prevention, of treatment, and that it does need to become much more of a partnership between public sector, private sector, and families. Young people say time and time again, and this session today with your question just proved it, that the most influential people in their lives when it comes to big decisions, including sex, are their parents. And so we got to help families to have those discussions, to know what services exist, and to start thinking about how they can use testing and engagement in care, et cetera, to keep young people healthy.
And what I've found as a great-grandmother, what I've found is very helpful is that you can't have the conversation with your child yourself when it's uncomfortable. Find a responsible person who can have that conversation with your child, who won't give them disinformation. And you know, somebody who doesn't just walk up to them and hand them all the things that are broken electronically in the house when they walk through the door and say, you fix it or you figure it out, because I don't know how to do this. We have a digital divide between the generations that has to be connected in some way. And we're going to have to figure that out, and we should figure that out quickly, because these pandemics are moving faster than we are.
Maybe
Anybody? Go ahead,
Maybe there's
Mark.
one additional, sorry.
Sure, go ahead.
Go ahead, Stephen.
Well, just going to very quickly, one additional point that just came to my mind, Vince, as you were speaking, when we talk about public-private partnerships, you know, with my healthcare hat, I think healthcare. But based on this question, we also need to think about our educational system. And so part of the public partnership ought to be schools. And as you just articulated, it's starting before middle school, or early in middle school, to have these conversations.
Mark?
I think in terms of one of the things we've done at ViiV that's been innovative is what we call cultural interventions. So I think anybody who has a child in your life knows that talking to them is like the Charlie Brown thing. It's like squawk, squawk, squawk. But what we found is we developed a play based on the lives and experience of black gay men. And we ran that. We ran it first in the South, in Baltimore, and then Jackson, Mississippi. And then we actually brought it to Harlem. I wasn't sure if it was going to play because it was actually based on Southern experiences. And then we ended up at the Public Theater here in New York. But a couple things about that. One is that we got people to spend an hour and a half immersive theater experience in the experience, in the topic. So they're talking about getting your diagnosis. They were talking about disclosure. They were talking about interacting with family. They were talking about the church. And then afterwards, we had what we called a talk back. And what we found is that, you know, spending that much time in the subject, it's not like the bus stop where you have an out-of-home campaign, you look at it for a second, but then you stop seeing it. But spending that much time really allowed people to access it differently than if it had been sort of a one-on-one conversation. And people actually said that they were going to take an action based on that. And one of the ones I'll always remember is there was a young man that said he mentored young children, at-risk children. And he said he realized he wasn't gay, and he said he realized, I don't have anything to offer a young child that might be dealing with that, dealing with being LGBT, dealing with being at risk of HIV. So he was actually going to go out and talk to some people and find resources. And so I think thinking about things like culture, which, you know, the metaverse, they say, is coming, you know, but is where people are spending more and more time in terms of just their attention is on culture. So that, I think, is a place where we need to look.
Stephen, did you have something additional to say? You
Yeah,
good?
I'm good.
All right. If there are no more questions, go ahead, Shane.
Thanks, Deborah. First, thank you, everyone, for an awesome panel. A theme that you guys have talked about a little bit is kind of breaking down the silos that we have within the work that we do within the HIV community. But we also know that HIV intersects with everything else, mental health, substance use, unstable housing. And I'd be curious as to folks' thoughts on integrating more systemic-based approaches to our HIV work and things that we as a community should be looking out for as we kind of progress in our work towards our HIV treatment goal.
Stephen?
Sure. Actually, one of the I feel like I should always follow Vince, or
You
I should always be in a panel with Vince because he stimulates my brain. But as you were speaking and talking about the workforce, one of the things that came to my mind is that the workforce that we need goes beyond the clinical care, nurses and physicians. We need the workforce of mental health workers. We need the workforce of social workers. We need the workforce of counselors. And to your question around this endemic, counselors, social workers, mental health workers, physicians, nurses who have the capacity to take care of all, right? So it's HIV, it's hepatitis, it's STI, it's mental health, it's substance use, it's et cetera. So having the workforce with the breadth of experience is one important approach. I think also starting at the federal level is thinking through how our funding for these programs currently exist. There are siloed programs. There are siloed HIV, siloed hepatitis, siloed STI funding, and so thinking about how we can integrate funding at the federal level or integrate programs at the federal level. The funding may be vertical, but when we do programs, we can have integrated programs. And then at the state level, which is where my members operate and function, is how do we do state programs and state funding in an integrated manner. And I know many of our members are exploring integrated approaches to the syndemics of HIV, hepatitis, and STIs.
To add to that workforce description, would need to be some thought around cultural competency.
Yeah.
There needs to be cultural competency. We just did a program with the Black church and hired a 120 church workforce so that people that are on the ground in the community can go out and do vaccinations. People were not accepting vaccinations from just anybody. It had to be somebody that they trusted. We found the same with HIV. We had such a difficult time getting people in the community, you guys remember, to test. And then we got some Black ministers to stand up in public and take an HIV test for the first time. Jesse Jackson, everybody. And people started coming into the church saying, I feel safe and I want to take a test. I think that we're just about ready to close. The bell waits for no one. Go ahead.
First of all, thank you.
Dr. Lee. Absolutely.
When I think about the 40 years of trying to conquer HIV, I also think about the role of stigma and shame. And I'm just wondering your reflections over 40 years. Where have we done well? What more can we do? How do we conquer the second epidemic, which is the stigma and the shame?
That's a great question, Dr. Tang. We have not done what we are supposed to do around that issue. We're lacking in that issue. Getting the ministers to test was one way to deal with it. Getting leaders and other people in communities to give out correct information and not disinformation. You have to have trusted people to talk to people. You have to have people who talk about moral characters and moral standing to say, you're okay. It's okay to take a test. And if you are HIV positive, it's okay to get treatment. And having people in the community to give that message becomes critically important to stigma and discrimination. We've done some good work. Vince, you've been masterful at talking to young people and letting young people come in. And so well, all of you have actually, so has Ingrid with all of the young people that she deals with. But we have not done enough. And we have to understand, today is the beginning of Advent. And and Hanukkah yesterday. And I had to do a sermon this morning, actually. And both those events are about hope and expectation. Mm-hmm. We have to change our mind about our fellow man and give everybody the hope and expectation that they need so that they can stay alive. It's about choose life, and we've got to make them feel confident that they are worthy to choose life. So that's a great, great question, Dr. Tang. Thank you. Panelists, I think we're done. Thank you very much. If you please Give them your round of applause. Thank you. Thank you, baby. Thank you.